Hello, I'm Andrew Gase, your host for today's presentation. I want to welcome you back to the Brain Matters webinar series. While we're waiting for any latecomers to get on board, I want to remind you about our newsletter, the Neuroscience Monitor, which will keep you up to date in neuromonitoring. You and your colleagues can sign up anytime on our website. You have an event or news item related to neuromonitoring and neurocritical care, please send it to us. We welcome the return of in-person and hybrid meetings, and here are a few upcoming ones. We look forward to seeing you there at ASSET in San Diego in August, ICSD in Lyon in September, and NCS in Chicago in the end of October. We are honored today to have two speakers on the topic of promoting bedside precision care in the ICU. Dr. Brian Apavu's clinical and research interests are in the use of electroencephalography, neurovascular ultrasound, and multimodality neurologic monitoring for care of critically ill children. He serves on several multi-center research consortiums, including the Critical Care EEG Monitoring Research Consortium and the Pediatric Neurocritical Care Research Group. Dr. Brandon Foreman is an expert in brain monitoring in the ICU, using EEG to detect seizures and spreading depolarizations after brain injury. He is a member of multi-center collaborative efforts such as Critical Care EEG Monitoring Research Consortium and the Cooperative Spreading Brain Injury Depolarizations Consortium, or COSBID. He has co-founded the Translational Collaborative for Research on Acute Neurologic Injuries, a Team Science Award-winning organization at the University of Cincinnati. Please type in your questions during the talk. We will now play a pre-recorded presentation by Dr. Apavu and Dr. Foreman with a question and answer session to follow.
Well, hi, everybody. We're here to have a conversation between myself and Dr. Brian Apavu. My name is Brandon Foreman. I'm an associate professor of neurology at the University of Cincinnati, where I attend the neuro ICU there. I'm an EEGer by training as well as an intensivist, and have an interest in brain monitoring, specifically after traumatic brain injury, using intracranial monitors, electrophysiology, and understanding how the pathophysiology of TBI works and evolves over time for specific patients. And with that, I'll let Dr. Apavu introduce himself.
Hi, everyone. My name is Dr. Brian Apavu. I'm a clinical assistant professor at child health and neurology at the University of Arizona College of Medicine, and I practice as an epileptologist and critical care neurologist at Phoenix Children's Hospital in Phoenix, Arizona. And here I do a combination of EEG reading and consultations in the pediatric intensive care unit for children with acute brain injuries or those at risk of it.
So the discussion or the conversation today really is going to hinge around some work you've done recently, Brian, on the implementation of multimodality neurologic monitoring reporting in pediatric TBI management, which was published in Neurocritical Care recently. And this is a really provocative kind of paper to me, or work to me, because the idea of reporting is kind of interesting. It's sort of unique. Oftentimes we focus on specific monitoring modalities and their relevance to clinical outcome, but not how we interpret or how we report it. And so I think to start, if you could just kind of walk us through what you did and what you found, and kind of we can start the conversation that way.
Yeah, absolutely. So here at Phoenix Children's Hospital, we had been working with multimodal modality neurologic monitoring since 2014. And we, along with, I think, a lot of people throughout the community, have had this technology, but have also been trying to learn how we can use it to deliver effective clinical care. We recognize that after acute brain injuries, that you have this primary brain insult that places the brain at risk for further damage, and we know that secondary brain insults can happen, whether they as a result of brain tissue hypoxia, seizures, malignant intracranial hypertension, or all sorts of different reasons. And we have been using multimodal monitoring for a number of years, but trying to get the most out of it, and also taking advantage of sort of things we've learned and concepts that we've understood for some time, but how do we actually put it in practical clinical use in our intensive care unit? So, so with that, I'll maybe present some slides that sort of some of the work that we're doing. At our hospital since 2014, we've been taking care of children anywhere between 14 days of age to 21 years of age with traumatic brain injury in the intensive care unit who undergo intracranial pressure monitoring. Well, since 2014, we've been monitoring them with multimodality neurologic monitoring. And any patient that gets a continuous intraparenchymal ICP monitor with TBI when they arrive also gets continuous EEG. So when we think about these patients with traumatic brain injury, at least when it comes to pediatrics, we have some evidence-based guidelines for first and second tier treatments for intracranial hypertension. So if we have an external ventricular drain in place, we'll do continuous EVD drainage as part of our first tier therapy, including sedation, paralytic therapy, hyperosmolar therapy, or mild hyperventilation targeting PaCO2s of about 35 millimeters of mercury. And if we have intracranial hypertension that's refractory to that, we implement our evidence-based guidelines to use other strategies such as moderate hyperventilation, with PaCO2s of 30 to 35, trying to keep brain tissue oxygenation at a reasonable level, or considering pentobarbital, mild hypothermia, or a decompressive craniectomy if needed. So for our patients that we do this, I mentioned we do intracranial pressure monitoring. These patients will often get continuous EEG, but we also implement in conjunction with those a host of other modalities to understand other elements of cerebral physiology, whether they be brain tissue oxygenation. We use either an intraparenchymal brain tissue oxygenation device. We also can consider non-invasive measures such as cerebral regional oximetry, which is often what we do, especially in quite young kids, because if we're not very comfortable putting in a bolt. We also implement transcranial Doppler ultrasound as a measure to assess cerebral blood flow, and we use a helmet oftentimes to measure those values continuously. And of course, with these patients, for good hemodynamic control and monitoring their cerebral perfusion pressure really well, we'll also do invasive arterial blood pressure monitoring. So let me just say that when it comes to our guidelines in pediatric traumatic brain injury, a lot of our treatment-based guidelines are based upon measurements of intracranial pressure and the risk stratification that high levels of ICP or evidence of intracranial pressure hypertension is associated with poor outcome. But what is at play and what causes intracranial hypertension can be quite diverse, whether it be because of cerebral edema, obstructive hydrocephalus, impaired venous jugular return, or just intracranial arterial blood volume from stimulation or vent settings. These things also impact that ICP value, and they play much more. Information about them give us much more information as to what is the cause that an ICP elevation may go up, why we might, and how best to tailor it. While I mentioned it before to you, these different tiered therapies for ICP, these are first and second tier therapies, but they don't, just looking at a stage approach of using one versus the other or using certain ones and moving on to the next one, I think it doesn't, if your ICP is high, it kind of helps to know why the ICP is high. Is it a patient with cerebral edema, or is this a patient you're just stimulating or you have inadequate paralytic therapy? Understanding that helps sort of deliver a more effective method of delivering care. So with that, we think of multimodality neurologic monitoring in clinical care. For us, what our history had been was we started using these devices at the bedside back in September of 2014. So at that point, we had monitors, the Moberg CNS 200 monitors that were in place in our ICU, and they sat at the bedside. They synced with EEG. They synced with our IntelliVue monitors and our measures of cerebral oxygenation and our intracranial pressure monitoring and TCD measurements. And we could look at the trend displays at the bedside. So the rounding team could look at the data. They could look back how things were in the last 12 hours. If they felt skilled, if they felt adept with the bedside monitors, they could, toggle, how things looked within a 1 day period versus a 5 day period. But that was really the primary way that multimodality monitoring was used when we first, when our institution started using it in September 2014. And it really, I think we've gone through a gradual shift in changes of how we use the technology. So starting in August of 2017, we started working a lot more intensely with our IT department, saying, hey, there's a lot more to this device than just looking at trends at the bedside. If we can actually stream this data and we can make it available to other physicians across the hospital, if we can make it available to consultants who may be off-site or on call elsewhere remotely, I think that adds to its value. So in August of 2017, our IT department became very helpful for us for getting live access ports in all of our ICU rooms so that we could stream the data and actually look at it, not just at the bedside, but elsewhere. And then with that, having software like CNS Envision or CNS Reader in the past, being able to utilize that to review the data over and scroll through it much more easily on a laptop or or just at in another room allowed us to explore the data a little bit more better. And then in June of 2018, we gained some capacities to look at a lot of to compute a lot of different model-based indices of cerebral dynamics, such as pressure reactivity index, CPP opt values, brain compliance indices like the correlation of ICP pulse amplitude and intracranial pressure, things of that nature, and allowed that to be available to us for hypothesis generation and to aid in our clinical decision making. And then after all of this was in place, we decided in January 2019, we're going to follow a standardized reporting of multimodal neurologic monitoring, which, I will say, credit to Brandon Foreman here with me for talking, for really teaching me a lot about how he sort of does things at Cincinnati, and a lot of what we've started to implement here is really modeled on some of the things we've learned from him. So starting in January 2019, any patient with a traumatic brain injury who underwent ICP and multimodality neurologic monitoring started to get a daily report put into the medical record that summated daily events that happened in clinical care. So our workflow which we published in recently, is that patients arrive into our pediatric intensive care unit. The bedside team establishes their initial goals of care. So we're following our guidelines. In pediatric traumatic brain injury, it's getting your ICP. You target your ICP under 20. You keep your CPP at least over 40 for all children. Some patients who are older, we might target 55 or 60 depending on age. But we institute the guidelines and we establish that. And then in the first day, we're following the guidelines and we're setting metrics that are very specific, that are evidence-based. And then we put them in the ICU and we do multimodal monitoring. We look at EEG, we look at intracranial pressure, we sync all our data together and we integrate it. So that data gets integrated, it gets stored in a clinical server here. And then the team will communicate what their goals of care are, just based on their bedside exam and evidence-based medicine, and discuss it with myself as sort of the multimodal neurologic monitoring reviewer. And then and so the clinician who reads multimodal neurologic monitoring will use it for formal data review and analysis. The team also has that data available. They can go, every member of the team has access to reviewing the Moberg live or at the bedside. So So that data becomes available, just like with continuous EEG. If our bedside physician, neurocritical care specialists can look at the EEG themselves, and they also rely on an epileptologist who does a formal review. So also very similar in this process, we have our bedside physicians who can look at the data themselves, and we also similarly have an individual whose job is primarily to look at that data remotely and provide a formal report. And so both the bedside physicians and the multimodal monitoring neurologic monitoring reader will look at the data, and then we'll review it, and then we'll talk about it, and just each day decisions might be made. A decision might be, let's just maintain, we're good, this kid is doing okay, there's not evidence that they are worse, their intracranial pressure is worsening, that their EEG is getting any worse, they're acting very appropriately, and we're not going to change our daily goals of care. CP, if our target was CPP above 55, we keep it there. If our ICP is under 20 and CPP over 55, and just keep some light propofol or dexmedetomidine for sedation, that's what we do, and we go towards the next day. If we think there's evidence of secondary brain insult, if there's malignant intracranial hypertension, if there's impaired cerebrovascular pressure reactivity, if there are seizures, we change our goals and accordingly. And so really, this is sort of the work process that we implement to be able to use this data in real time. And so, with our reporting, we deliver a variety of different screenshots of the data that we do. So, I think we'll do trend displays, and what we can look at and being able to trend the display can give us some valuable information. So, for instance, this is a 9-month-old boy with traumatic brain injury that has an intraparenchymal probe in. As you can see in this multi-hour time scale on the left, there's episodes where this patient has intracranial hypertension, his ICP goes over 25. But you can notice, I have synced here not just intracranial pressure, but blood pressure, cerebral perfusion pressure, his cerebral regional oximetry, and his end-tidal CO2. And we can see that, there are plateau waves. There are times where the ICPs go up and they come down, but the manner in which it does that completely synchronizes with blood pressure, cerebral regional oximetry, and end-tidal CO2. So there is a direct correlation between that intracranial pressure as well as those other modalities. So for us, we often see this when a patient is just being, is being stimulated, and their blood pressure. If they're on light sedation and then you do your nursing cares or stimulate, you'll rise their blood pressure. You may change their vent settings, or they may you may get a rise in end-tidal CO2. Your cerebral oxygenation goes up because you're increasing your intracranial arterial blood volume, and this is sort of the pattern we see. And this is the type of situation where if we see that intracranial pressure changes directly match our end-tidal, our RSO2, that's a situation that we don't really, that we feel pretty comfortable that this is a blood volume issue and not a malignant cerebral edema issue or not an obstructive hydrocephalus issue. So this is the type of patient where we will stay within our tier 1 therapies, where we want to give we might do sedation, we might improve our sedation, we might do initiate paralytics, and this is not the kid that we would think about, oh, they need a decompressive cranie, or oh, they need to be put on pentabarb. So it allows us to feel more comfortable when we see the ICP going up and down. If we see a direct measure of cerebral oxygenation or two measures of oxygenation and blood flow delivery that tell us that this is all that's going on, we feel a lot more comfortable about it. And then with these screenshots, we can create scatter plots that just reflect, for this patient, there's a direct relationship between end-tidal CO2 and that cerebral NIRS. There's a direct relationship with blood pressure and NIRS. And so we derive a better hypothesis about what happened during this period of time. This is just another example. So this is our use of transcranial Doppler in a 1-year-old girl with abusive head trauma with refractory intracranial hypertension, who already went to decompressive craniectomy. So her ICPs stayed for multiple days, over 20, despite pentobarbital, a decompressive craniectomy, and just a lot of aggressive tier 2 therapy. And so, we put her on a transcranial Doppler ultrasound helmet. So you can see at the bottom 2 rows, the left and right middle cerebral arteries. And as we manipulated vasopressive agents, when we manipulated her norepinephrine, you could see that her intracranial pressure and her arterial blood pressure really moved in the same direction, along with her left and right TCV mean flow velocity. So this was reflective that she did not have very good intracranial, she didn't have very good cerebrovascular pressure reactivity or cerebral autoregulation. And so for her, after failing tier one and tier 2 therapies to manage her intracranial pressure, we tolerated bringing her CPP goal from 55 towards the lower end of our evidence-based guidelines for children of 40, and we're able to successfully get her ICP down. So this is sort of another way and to communicate those results with the team, and to establish that we're going to go for 40 instead of 55, and justify it. I think showing that, being able to display and communicate and demonstrate, in this sort of a scatter plot, that you really don't have evidence of cerebrovascular pressure activity or cerebral autoregulation really becomes quite valuable. So we summarized some of the clinical decisions we made as a result of between 2019 and when we completed our analysis, I believe in August of 2020. All of our patients, who underwent reporting, we looked at the data, and it helped us decide when we were going to image, if it was safe to image at a certain day, if it wasn't safe to image. For some patients, we tested putting their head in the bed flat and calculated a dose of intracranial hypertension or percent of time that their ICPs would be above 20 if we laid them flat. If they had to go for cerebral angiography, if they had to go for long abdominal surgeries, and the question is whether they would tolerate whether they'd be able to tolerate laying flat in those sorts of situations, as without any sort of intracranial hypertension or risk for herniation. So we often would just do that and use our multimodal monitoring data to prove, they were safe. We use the data on a couple of kids for paralytic therapy. We use the data to escalate or de-escalate hyperosmolar therapy and to look for its treatment efficacy. We use it for a few patients for adjustment of pentobarbital therapy. We used provocative cerebral autoregulation testing to decide where we would target our CPP for a number of patients. We do use continuous measures of cerebral autoregulation, like pressure reactivity index or CPP op values, to explore patient data, but fundamentally we test autoregulation by actually doing maneuvers that are provocative at the bedside. And then we look at that, make a decision, and as we talk to our muscle disciplinary team, we show them these displays so that we really communicate with them, and just why we're thinking what we want to do. For a lot of patients with issues related to hypoventilation or increased intracranial blood volume, we may lower or adjust PaCO2 values. We've used evidence of refractory intracranial hypertension to image and see malignant cerebral edema and decide on late neurosurgical interventions such as an external decompressive craniectomy or an EVD placed if it wasn't initially, and so forth. So. And for a couple of kids who were really bad and showed poor evidence of poor cerebrovascular pressure reactivity, the demonstration of it and its communication of injury severity for those patients were used as part of prognostication discussions. So these are sort of the decisions that we made using this framework. It's pretty diverse. For the most of the time, we're not making a huge decision. We're not making some major care altering decision. It's just this timing when we might extubate a patient, when we might image them, and when we might get monitors out. And then in special circumstances, we adjust tier 1 and tier 2 therapy accordingly. And so for us, when we looked at a variety of quality improvement measures to understand how they were doing, how we did with multimodality neurologic monitoring reporting. And there were two things that for us were interesting, and that is that we observed a decrease in both our ventilator days and our intracranial pressure monitoring days during the time that we were doing the reporting, compared to the time when we were doing multimodal neurologic monitoring but not providing reporting. This was a change that we noticed, and we're quite pleased to see this. While there can be a lot of reasons why ventilator days and ICP monitoring days go down, that have to do with a lot of great people's work and quality improvement and just good clinical care, improved clinical care that's been happening in our hospital over the last several years. We do think that having the ability to think this, to look at this information in a more thoughtful manner, and to really test our think about our hypotheses and test them, it really helps us just deliver a more effective clinical care. And we really think that's been a part of our improvement in overall quality improvement metrics, in terms of reducing some of the burden of ventilation and ICP monitoring days that our patients have had. So, I think this is a supplement from our article, and it's a decision tree that's very complicated, but I think it sort of reflects a lot of the ways that we approach multimodal monitoring. There are fundamentally two things we start out with when the kid arrives to the ICU. How's their ICP and CPP doing? And then how does their EEG look? If their ICP is under 20, their CPP is above 40, we're hitting our targets and guidelines, and they just have sedated sleep features, that's a kid we feel pretty good about. And if that sustains itself, we'll check their ICP by keeping the head of the bed flat. We'll get our neuroimaging, and then we'll move toward extubation and just getting them to the rehab stage. But if we see things differently, then everything gets a lot more complex. So if our ICPs are elevated, or if our cerebral perfusion pressure is insufficient, we start correlating what correlates with the ICP. Does it correlate with cerebral oxygenation and end-tidal CO2? Then it might be more stimulatory. Is it associated with plateau waves? Maybe we need, and stimulatory plateau waves, maybe we need some paralytic therapy. If there's seizures or background EEG abnormalities, then we start to think, okay, what are we dealing with here? Is there secondary brain injury? Is there malignant cerebral edema? And then do we need to sort of battle things there? So while I don't want to, so I think it might be, if you get a chance to read this article, take a look at the supplement. It's a complicated slide, but it does give you a sense. We start with the EEG and the ICP. We try to look at our goals, and if we start to see abnormalities here that are, if we don't see abnormalities, we feel pretty good, and we move toward the rehab stage. But if things don't look so good, then we move in a different direction. Okay, so let me unshare my screen there.
Great. I mean, this is a fantastic work, in part because I think it speaks to a lot of what we do as clinicians, kind of without systematizing it, right? We tend to see our patients and we put all this stuff together kind of mentally and make decisions about what to do and make changes and see what happens to them. But, to think about looking at large swaths of this data, if you're looking at an overnight record or 8 hours of data or something like that, it becomes a lot more difficult to figure out how to do that at bedside quickly in a way that's responsive to what your patient needs right then and there. And so it's kind of nice to see that, much like in the EEG world, where we know EEG impacts decision-making clinically, that this is kind of an analogy to that it actually can generate some changes in decision-making simply by kind of having this bird's eye view of what's happening to that patient over time. To kind of start, the conversation about what you're doing specifically, and kind of why you started doing all this stuff. When you started doing the reporting piece itself, what was your kind of rationale, and what was the gap that you felt like that reporting was really filling?
Yeah, absolutely. Great question. I think I think for a lot of us that practice in the ICU, whether as consultants or as primary intensivists, when we start our rounds or when we hear about past events, if we're not able to sort of visualize it and see what happened in a really good manner, it's hard to deliver sort of a thought of what could have been the cause of it, cause of problems. And then it ends up being a lot of hearsay. The nurse was doing something, or oh, somebody tried something and it definitely worked, but you can't actually see that. If I think about like sports, for instance, if you play, if there's a football game that, or let's use basketball, the NBA finals are on. If there's a basketball game that's occurred, if there was the Western Conference Finals was on yesterday and it was a controversial ending, people are going to be talking about it. People are going to be talking about, what one player did and whatnot. But if you, but it doesn't mean as much to say anything unless you actually. But then what do they do in sportscasting? They show the video, they show the event, they show where people were positioned and why a player was successful or not successful, or why a play was good or not good. What multimodal neurologic monitoring does is when you start your morning and you hear about these events that happened overnight and what might be the right play for this morning, it helps to actually see the maneuvers, to see the different things that are at play. If ICP went up, like what drove it? What looks like it drove it? If a med, if something bad happened after a med, when was that given and how did it affect things, and whether that affected cerebral oxygenation or not? Or if something really helped, if ICPs were down, were terrible, and then everybody's convinced that something did it. And then actually looking at what event, improved the ICP and then how that affected the EEG. I think that ends up being very valuable. So I think that going beyond, clinical perception of events can be inaccurate. There's a huge amount of data to go over. It can be hard to extract, what actually led to what, and we sort of just have to. We use our best estimated guess, but to actually have the play-by-play, the feedback, what they call in the sports world the Monday morning quarterback sessions, to actually have that available, actually, I think helps us, decide what we're going to do. And then if we do decide with some sort of controversial, if we're going to come up with if we think there's a way of treatment that doesn't make everybody comfortable, this helps with the communication. Like if we think the best thing is to bring that CPP in a child from 55 to about 40, some people may not be comfortable with that. Some people may not be comfortable with you just saying that this patient's not autoregulating. But if you can show them that, if you can show them why you think that way, then you make a stronger argument, and you make more of your team more comfortable with what you want to do. And then if you do something and being able to actually look and see that it helped, I think that makes people comfortable versus sort of just deciding you're going to do something and then, not having and then walking away and then not having the data to show and demonstrate that it actually did help.
Yeah, I think that's been one of the things that's come across at our own shop, doing this similar thing is, when we first kind of put the monitors in the room and started using them, no one really used them. I mean, they were in there and you could use the numbers and respond when the bedside staff would call and say, well, your ICP is elevated, and then I started noticing that, you'd have people responding to the numbers in ways that actually threw off the rest of the numbers. And so I show examples when I give talks of someone treating an ICP, and as they do so by reducing the CPP, they don't realize that they've dropped the brain tissue oxygen, creating brain tissue hypoxia. And you wouldn't know that unless you kind of step back and look at what's happened over the record and make some inferences about that particular patient. And so we started more regularly stepping back, just looking at the data overall. And, one of the things that I found, and you've kind of alluded to this in showing some of the examples, is that there's a lot of relationships between physiologic variables that are really practically useful, but oftentimes you can't see those at bedside. You really do have to take a bigger view. And so we kind of started reporting this stuff in our medical record for a similar reason, which is to communicate, hey, this, you may not know it, but this is the stuff that's going on. And in doing so, kind of letting everyone get on the same page as they're starting to make those decisions for kind of what that plan is going to look like for the day. And I think that's a huge benefit to doing it. And so kind of showing that as you've done in this work is really, really nice, I think. It's, I think, hard for a lot of us to get our heads around, like, what do you do with all this data? And so if you kind of think about it more in the sense of, well, use it to explore what's happening to your individual patient and make decisions for that individual patient, it kind of reframes the whole thing in a lot of ways. And it, it doesn't take an expert in one thing or another necessarily to do this. You just have to kind of, be comfortable enough with looking at the physiology and starting to put those pieces together. And more importantly, testing out your hypothesis, which I think you've alluded to a couple of times, this idea of you think maybe there's a response in the ICP every time the blood pressure goes up. You can test that. And, and those kind of physiologic relationships really do drive care, I think. And you've shown that pretty convincingly here. When you're reporting this stuff, the tendency, in my mind, is to say, like, I'm seeing this, and I'm seeing this, I'm seeing this. Hey guys, do X, Y, or Z, right? I think that's one of the things that you come across when you start looking at this stuff kind of from behind the computer screen. How assertive are these reports when you're communicating this stuff to your the clinicians who are there at bedside, and what kinds of things are you reporting in terms of being prescriptive or interpreting, or how do you handle that?
Yeah, I think it's valuable just being experienced sort of on the epilepsy end or epileptologist end, and thinking about this with the same approach I do when I read EEGs, or a lot of people do, or I've learned from that read EEGs, which is to be somewhat conservative. If you're not actually taking care of the kid and you're just looking at data, I think it becomes it becomes a little challenging to be overly prescriptive. You don't necessarily know everything. You may not have looked at the imaging, as well, to look at, whether you're gonna, whether going up on this, driving that CPP high, if you don't have a good sense of regional autoregulation in an area where there's a massive posterior fossa hemorrhage, driving CPP up, driving your CPP high might not be the best thing. And so it becomes a little bit challenging. And I mean, I think the same thing occurs, I think for any epileptologists or EEGers, listening in the room, we can say stop status epilepticus. We can ask our ICU teams to stop the seizures as soon as possible. But if they don't have an art line in, if they're hypotensive and you're saying to give pentobarb or go way up on your midazolam, that's gonna, you want to stop the seizure, but you have no idea what you're doing to that patient. And so in the same way, I think, if we're not at the bedside, we do need to be not terribly prescriptive. Now, I think the teams, teams may want, bedside teams may want some recommendations, and I think it fundamentally comes on them. If you give some ideas or some suggestions, I mean, I think they have to take it into context of the patient that they see in front of them. And then I think the key also is, provocative maneuvers. I think looking, if a med work if a bolus of mannitol seemed to really, do the trick to reduce intracranial hypertension, and where your serum and osmols are, and where what your situation is, your patient's sodium value, and you think another bolus or a bolus of hypertonic saline is going to be the next right trick, the team can do that, and they can look at the treatment effect, and that plays a role. So I think that's kind of the beauty of this monitoring, is that you don't want to be that prescriptive, if you're not there in real time, and if you're not at the bedside. But this is a tool for everyone. It's not just for somebody to review remotely. It's for people to review in the bedside. So if the team is comfortable trying a therapy that they can control if something adverse happens, and they also feel is safe, they're empowered right there and then, especially with a bedside monitor, to look at it and to confirm with myself or someone who's remotely monitoring whether things improve. So, I mean, I think, one way you could think about it is if you, I think if you have a patient where you have, if you have a patient with like really significant slowing on their EEG on one side, and worsening intracranial hypertension, and you gave a bolus of hyperosmolar therapy, and you see some improvement, and then you get a call from your epileptologist saying, hey, the EEG looks a lot better on that left side, and pick up at faster frequencies, and you're like, okay, you got this synchronized, you get this information that's really useful. You decreased cerebral edema, you may have increased cerebral perfusion, and you may have improved cortical function. And so in the same way, like the bedside physician can look at certain elements and can look at improvement in certain elements, and it also aids in having another person, looking at the other, the combination of higher complex elements that you need to analyze more remotely or more carefully, if that makes sense.
So practically speaking, who else is doing this besides you at your shop?
Yeah, so that's a bit. So right now we're still in our infancy. So I'm primarily the person that does it. Everyone in our critical care neurology staff knows how to. Every member of our critical care neurology service that practices at that rounds has access to the information itself and looks at it. Our primary critical care teams also look at it at the bedside. So, but the actual reporting is primarily done through me. Our long-term goal is that this needs to be a more a larger system, and that we have multiple people who can be on a dedicated service and providing it, and also providing second opinions. So the way it works, but right now in our sort of infancy stage, is that I'll deliver that information. Everybody has a chance to review it themselves and to look at it themselves and to reanalyze more complex data themselves, and then just take things from there.
Yeah, it's been this is the same at our shop. It's I'm the one doing the reporting, in part because there's not really any standards in terms of what data must be reported, and there's no definitions in terms of what kinds of relationships you might see. If I'm reading an EEG and I say there's an epileptiform discharge, everyone kind of knows what that means in a sense, right? But that doesn't really exist for this particular type of service yet. And I think that that's something that needs to be developed, because the more you see these relationships, the more you can define them, quantify, and report them in a way that people go, oh, I know what that means. But until then, it's a little bit tough to kind of have, I think multiple people reading this in kind of the same way. We're all going to take away something different. So I like the idea of, right now it's still in its infancy, as you point out. It's definitely moving toward needing to be really a service line that is integrated with the clinical care, such that we start making these inferences and start defining what it is that we're seeing in a way that you can sort of pass along and people know what you're talking about. And
yeah, I think it was. Oh, go ahead. Sorry.
No, go ahead.
Yeah, I think it was interesting. I know there was a publication recently in Neurologic, a Delphi survey that focused on autoregulation, and there was, if I recall, there was quite a diverse set of expert opinions about what's the right way to test for it. And I think I think it's I think some of this may I think some of that and having more consensus is going to be a necessary part to maturing this field and maturing, what elements should be reported in multimodality neurologic monitoring. And I think, my bias of what based on my clinical experience, is what's going to happen is there isn't going to be like a perfect modality for everybody, but there will be the right modalities for the right patient. Some of my patients, if they're like, if I got a patient that's on needing significant amounts of sedation, and you don't see that much oxygen extraction on their NIRS is, their FiO2 is high and their NIRS value is kind of static at like 95 or whatnot. My NIRS isn't going to give me a lot of useful information, but my EEG might, my TCDs might, my continuous ICP monitoring might. And so versus another patient, a small infant, where I can't, a small infant where my NIRS might be wonderful, and give me wonderful variability in values for us that infer cerebral oxygenation. So I think I think that's a challenge that we're gonna have, is gaining consensus of what tools to use for who, and then also recognizing that there may be certain tools that are more useful for certain patients at a certain time. I think that'll be one of the things that needs to mature. I think the other thing that probably needs to mature is I think we just need to get a lot. One of the limitations of the study of this single center. This is our experience at Phoenix Children's Hospital. I think it's not. I can't say that this is generalizable to other institutions. You guys will have at Cincinnati probably have your own experiences. You guys use certain modalities that we don't use, and vice versa, and we'll get different experiences from that. But I think there probably are a lot of patterns that probably exist that we can share and understand a little bit better. Just like the EEG, the ICU EEG community, collaborated and sort of learned, over the last 10 to 15 years, what lateralized periodic discharges were, what stimulus-induced rhythmic periodic discharges or SERPIDs are, and what ictal and interictal continuum patterns are, and how they confer risk towards injury and poor outcomes. I think the more that we all do this, and the more that we all sort of share similar findings, the more we're going to recognize things that ought to be reported and ought to be, right now, if you see lateralized periodic discharges on the EEG and you're an epileptologist, you need to report that. That confers risk for seizures, that confers potential injury if you have no other reason to see those. And I think we're going to, with our field, we haven't matured to the, obviously a lot of us are doing things in single center fashion right now. We haven't had a chance to sort of, look at each of our data and see if we find similar trends. But I think that's maybe where we go as we try to mature this.
Yeah, I completely agree. Well, and even the difference between pediatric care and the stuff that you find and the adult care that we provide and the stuff that we see in adults, there's similarities, there's certainly differences. And, it's going to take, I think, a lot of us kind of coming together to say, well, here's what I'm seeing. Oh, my gosh, I saw the same thing. And look, here was the kind of clinical correlation. And that's going to be really critical. I do think one thing, just to highlight is, if you're kind of watching this right now and you're thinking, well, we do a couple of these. We have NIRS, we have ICP, and but I don't have blood flow monitoring, or I don't have robotic TCDs that give me continuous data. There's not really any consensus too as to what constitutes multimodality monitoring. I think the key is if you're using more than one kind of measurement at any given time to try to infer what's going on with your patient, this is what we're talking about. And so really anybody at, anywhere that's doing anything like this, you can kind of reuse the same framework to sort of put your data together and try to figure out what's happening to the patients that you're monitoring, whatever the modalities you happen to have available are. You certainly don't have to have some complete package or some subset, to make this work. One of the things that comes up, for places that are starting to do this, though, they're getting the equipment that they want to use, or they're taking the equipment they already have and kind of putting it together. How, from a practical standpoint, let's say I have a latent interest in this stuff, and I really want to take a deep dive and look at this stuff in real time. How long does it take from a practical standpoint to actually do? Like, what kind of time commitment do you have to make to do this kind of stuff?
In terms of reporting, or in terms of
in terms of reporting, kind of using it in the way that you've described here.
Yeah, I mean, the way we do it, it probably I will say that with really good IT support, which we have, and with really good computers and servers, which we have, it probably takes me about an hour to review the data, and that's with, so I review the data I'm able to review the data in a virtual machine that sits within our hospital network, and that virtual machine has a lot of power behind it, and a lot of, and so that aids in sort of post-processing data, in live review. With all of that working, it still takes it takes about an hour to review and summate a 24 hours of data, and that's for one patient. So if you're if you got a lot of trauma, and you got like multiple traumas in your ICU at a given time, you're going to be taking more than an hour. You're going to be taking a lot more of your time. So that's what it takes for me. And then I think, if I wanted, and I think this is where, I think as the field sort of matures, it's the complexity of the data. If I really wanted to go into fine detail about EEG changes, and really reviewing, whether ventilation changes improved alpha percentage in an area of penumbra. That's something I do, but that adds a little bit more complexity to that hour. So I think, if I'm just looking at whether goals of care were met, like if their ICPs were under 20, if their CPP was above 40 or whatever we set, 55, 60 for the per patient's age. If I am looking at things of that nature, if I'm looking at autoregulation on continuous measures, it still takes me about an hour. And then to review each of the medications, boluses of therapies, and whether they impacted intracranial pressure, brain tissue oxygenation, it'll still take me about an hour. But if I wanted to really focus on specific events, like I showed that one figure of continuous TCD, I mean, that's a little bit more of an investment to look at, what happened as flow, as that came together, to make the screenshots for unique modalities, for EEG changes related to ventilation or medications. So I think at minimum it takes an hour, but the more fancier you want to get, or the finer detail you want to extract, it takes longer for me. What's your experience?
It's been about the same. It's about an hour per patient, realistically. I mean, it really is a service, to be fair. It's definitely distinct from reading an EEG, although, reading a raw EEG takes 20 to 40 minutes, depending on the topic. So not too different, but then you roll in all this other stuff, and it really does. It takes about an hour. I actually really enjoy it, though, because you end up pulling up things. We have a remote access instantiation of the CNS and vision software ourselves, and so our ICU faculty can all log in. They can see the stuff from home or wherever. But you come in the morning, pull it up just like you would an EG, and end up going through all the stuff and getting the report in by the time they're starting rounds. It's very doable, actually. It's just, it's one of these things where it does take a little bit of time. And the more you do it, obviously, the more efficient you get, and having kind of a standardized way to look at stuff and getting used to the way that you tend to kind of outline your workflow helps a lot. And so it's definitely feasible from, kind of a dedicated service perspective. What is not so feasible is if I'm actually in the unit rounding and I've got one of these patients in, I can't review everything and they're at bedside during rounds. Forget it. I mean, it's too much. And I can always go back and look at the bedside at what's going on, or make, comments, or kind of expand and contract stuff. But the ability to kind of, sit down and look at everything in aggregate to generate the insights that you're generating, I think, and that I feel like I generate too, and I see this stuff. You really have to kind of step back. It's not certainly something you can just kind of, I think, do at bedside, which is it's a little bit different in terms of the way I think we frame it when we look at the data this way. Yeah,
I think we probably have different experiences. I think correct me if I'm wrong. When you're in the ICU, you're primary. So and for me, when I'm on the ICU, I'm a consultant. So I think I have the luxury of not worrying about of having other my primary colleagues focus on ventilation, focus on line placement, focus on infections that might be brewing and whether the right antibiotics are in and things like that. So for me as a consultant, I do feel a little bit more liberty to focus on the data. And for me, when I'm there, since I don't need to manage the vent, I don't need to, I think, I mean, look at all the lab work that relates to, abdominal traumas and PT, INR. I think the fact that I don't have to focus on that, but I do get to look at the framework from the bedside. I think that's where, for me, it's I do find a unique insight, being providing in the situation where, I'll still provide the reports, but I also am at the bedside. And I think when I'm on service, as a consultant, I do get, just because I don't have to worry about those other things. I got my colleagues on the pediatric critical care side to really focus on those. I think I learn, and I think it sort of modifies when being able to be the person to do the bedside provocative maneuvers. Now I do it as a consultant. I do that really with an intensivist in the room or an intensive care fellow in the room. Like I personally, as a critical care neurologist, I don't change the vent settings. I don't order the pressors. I don't do that. I come up with a plan with the pediatric intensivist. I go in with a pediatric critical care fellow, and then they really fundamentally make the maneuvers. So like I may want to hyperventilate, or may want to drive PaCO2 down, but I'm not the right person to decide whether that's tidal volume or respiratory rate. I need my colleague to do that. And so, so for me, I think as a consultant neurologist, it plays a little bit as a unique perspective for me. But I could totally understand if you're sort of primary and you have like all these different components that you're responsible for, that it can perhaps be information overload in that situation.
I really put on my hat essentially as a consultant when I'm doing the multimodalities kind of reading and reporting, because I do think there's some benefit in kind of having that different viewpoint, and then integrating with the neurocritical care team and the neurosurgery team to say, hey, here's what we're seeing, but keeping it very separated is really, really useful, I think, and enhances care as opposed to trying to roll it all into, my bedside clinical care for sure.
Yeah, I mean, I think what I'm seeing, and I'm learning, even as sort of where I am in my career, I'm learning quite a bit about, I think from my critical care, colleague, my pediatric critical care colleagues about, where they carry expertise for these specific patients, and where, my background may not be such an expert. And the more and more I learn from them, the more I realize that when we take care of critically ill patients, there's an information overload about the amount of things that we have to be, as a team, really responsible for effective clinical care. And the more we learn about multimodal monitoring and secondary brain injury and the real-time pathophysiology, we really see that this is a huge focus demand is just on this. So being able to be in a position where you deliver that as your specific line of care seems for a lot of patients to be something that's needed.
Is there a kind of value proposition that you were able to sell to your system, or to kind of allow you to have the freedom to do this kind of stuff? And how do you kind of broach that subject of worthwhile?
Yeah, I mean, there's a couple of things that sort of work for us. I think in terms of making a proposition for value analysis, I think if you have a history of demonstrating clinical benefit, even through cases, like that can be one component to what you do. I think if you really needed an ICP and a TCD together, or if integrated data, I think that if you can demonstrate the value of integrated data, especially even in just case examples of how it provided clinical benefit, that can be of utility. I think one of the fears about multimodal neurologic monitoring that I hear about, and that even is a point of discussion, early on in our early adopted use of it, 2014 to 2017 is, are we prolonging care? So, the thing is, like, secondary brain cell assault can happen. It's a problem, but you also want to make, and we have all these different thresholds in traumatic brain injury and neurocritical care that we have to follow, like keep ICP under 20 or 22 for adults, keep CPP above 40 or 60, and then what if you're not doing that? And, like, do you need to escalate care? And then do you need to go up your tier 1 and 2 therapies? And then I think the more, the problem, one of the challenges with multimodal monitoring is that you get a lot of data, and you get a lot of aberrancies. You get a lot of situations where, you find your threshold wasn't met. And then does that mean you need to escalate care? And I think that's some of the fear that exists, I think, in the in the critical care world about multimodal monitoring. If you're going to, over treat patients and prolong their course of stay, But I think where I think the field can benefit, and what we hope to demonstrate through this paper, is that the hypothesis generation is really the key. It's not, making every second of the patient's 7 days with ICPs under 20. I mean, sometimes it's going to spike up. The question is, does that spike represent secondary insult? Does that spike represent something that's going to actually make the patient worse? I think that delivering the right hypothesis that an aberrancy is a problem, I think that's where there's value. So I think with this, at least at the moment, I think this was a helpful for us because we're demonstrating that we can do this well. We can do this. We're actually having a decrease in our ventilator days or decrease in our ICP monitoring days, and hopefully we can show. Our hope with decreased ventilatory days, we'll show. We'll be able to demonstrate that our ventilator-assisted pneumonias and things like that are going to go down correspondingly. So I think having a system in place and demonstrating that it is a part of effective clinical care, and then showing case examples of where that's of value. I think that's what helps. And of course, the other value proposition is in research. Like we're getting really interesting data from this. There's opportunities to collaborate with other centers that get similar data and to bring in research opportunities. And so I think it's this is innovative technology that I think more and more of us are using, and more of us are getting an opportunity to talk to each other and come up with projects and potentially funding opportunities. And so that also adds, in an academic hospital value proposition as well.
So you think, kind of having seen as much as you've seen, and I'm of course biased, I've kind of done the same as much as I've seen. I sort of have an answer to this myself, but do you think that this kind of setup, this kind of workflow, where you've got, multiple different measurements that you're using and kind of this time lock, data capture device that you're able to review and report, help teams kind of with decision making, do you think it's ready for prime time? Like, is this ready for other hospitals to say, oh man, this is what I want to do. This makes sense. Let's do it.
I think so. I think what I think it's important. Yes, I think so, and I think it's important in what context we use this. So I think this doesn't replace guidelines. This doesn't change what we know about what biomarkers are associated with favorable and unfavorable outcomes for our patient populations. I think we have these thresholds are still important, and we need to set them sort of at the onset that when our patients arrive. But and then how this monitoring doesn't change the therapies that are available to our patients. Hyperosmolar therapy will always be an option. Hyperventilation, mild hyperventilation will always be an option. I think paralytic therapy, sedation, decompressive craniectomies. These are all our options. These are all the plays in your plays in your game. And then I think what I think what changes is perhaps how you play, like what play you make at a given time. You think about, I don't know why, I watched NBA. I watched the Suns play yesterday, so that's like my analogy right now. Your players perform. In basketball, your players perform. They hit their shots. They each have some players are good at dunking, some are good at 3-point shots, some are good at the free throw line in different places. So all of those, the players are still there. The plays still stay the same. How you react to the defense is what fundamentally changes. And so I think that's where here it's, I think, you have different pathophysiology, you have different, setups for secondary brain insult. And so your plays don't change, but this helps you design, how you're going to respond. Does that make sense? All right, I wanted to know what your perspective was.
Yeah, well, I mean, I think you're making, in a way, a point of saying we're already kind of doing this. I think this sort of stuff is already out there. People are already using it, to varying degrees. And whether it's, a place that's using ICP alone, you're still incorporating your arterial blood pressure. You're still looking at CPP. You're still trying to infer whether someone needs more driving pressure to reduce the ICP, or whether it's going to make things worse. We're already doing this stuff. And so I think as we start increasing complexity, we're, I think, finally starting to turn a corner where we realize that it's not just one measurement that matters, right? And there's been papers just in the past year talking about the need for better heuristics, for better ways of kind of thinking about how we're treating these measurements that have, kind of previously been monolithic, like ICP. But we're also faced with this kind of difficulty when we're talking about things like diagnostic devices, which really this is. We're talking about devices that aren't meant to be therapeutic. These aren't interventions that we're talking about. Really, it's diagnostic devices that are aimed to just inform. But when the measurements are so complicated, they can't really provide meaningful information about someone interpreting it. That's, I think, the gap that we're talking about. Certainly the gap that I feel like I'm filling when I'm doing these reports as well. But and so, I think it's time to do it in a better way, I think, and do it in a way that sort of is more helpful than it is just kind of setting it up and letting it run.
Yeah, I think, I think where, I have caution is maybe, there are like some promising, methods. I think, when I started doing multimodality monitoring, a lot of the research that existed, focused on a lot on like machine learning techniques, predictive analytics techniques, and these are going to be really important for research and maybe operational, in the future for us. But some of that stuff I don't think is ready for prime time. It's just using the modalities and knowing how you deliver care and choosing the way you deliver care, using the tiered therapy, the tier 1 and tier 2 therapies that are available to you. I think that's ready for prime time. There's research to be done on, definitely on continuous measures of autoregulation, on algorithms that can predict intracranial pressure before, intracranial hypertension before it occurs. These are still, I think, emerging. We're not gonna. I don't think we're ready to treat ICP before it goes up just based on a machine learning algorithm. But so I think that's not, that type of stuff, maneuvers are not ready for prime time. But our basic, methods of care, and then using our basic understanding of the pathophysiology of the injured brain and how these modalities infer information to us and how they integrate. The hypotheses can be generated about pathophysiology, taking integrated data of cortical function, blood flow, driving pressures. I think that's ready for now.
Yeah. The idea of using some of these computational techniques is super attractive because of the complexity of the data. But ultimately, anytime you talk about these, computational modeling and predictive analytics and even decision support, it's got to be informed by clinical practice. And we're, I think, in a position now where we can start defining what we're seeing and trying to arrive at some consensuses about what some of these patterns are and what they mean. But all of those are kind of the precursors to defining any sort of kind of automatic algorithm or some kind of some analytic tool that would help us out. Really, I think it's going to take that it's got to take the human element, the clinician, to be able to say, yes, this means something to this patient at this time, and and here are some things that I know I can do to help adjust, mitigate, treat, whatever the case may be. So I think we're at the cusp of actually needing the human intervention, the human expertise, well before we start using the data science, tools that are readily available. As much as those are attractive, and I think are going to be in the future in some limited ways. We see this with the CPP calculation, which I think is fantastic. It's a great proof of principle, but the work that went into identifying what that is, what it means, and how it can be calculated, spans 20 years, right?
Yeah, absolutely.
And we're just on the cusp of doing that for all of these other different modalities, which is super exciting, and not to be daunting, I don't think, for those out there who may be thinking about doing this or have kind of thought, wow, this would be kind of cool to do. You just kind of have to dive in and you start seeing stuff, right? And
yeah.
At the end of the day, it's kind of how ICP monitoring started, right?
Right.
You transduce this ventricular drain you put in, and all of a sudden, wow, okay, there's a lot of stuff going on here. What does it mean? What am I seeing? And so we're 60 years down the line and ready to do this, I think, looking at different aspects of brain physiology beyond just pressure.
Yeah, absolutely.
So do you want to, I think you've got a conclusion slide. I don't know if you want to pop that up. Maybe we can kind of say a couple last words. And then my hope is by the end of the webinar that there will be some interest in asking some questions in a chat box, or maybe even asking verbally. And then we'll plan on having a live portion where we're available to you guys just to bounce questions off of, ask for some maybe additional detail, things like that. So we'll kind of conclude the recorded part and then, open the discussion up to those of you on the call.
All right. I think that's a good place to end.
Thank you to both of you for such a terrific presentation. Once again, please keep sending in your questions to everybody who's viewing this. We're now going to go back live to Dr. Apavu in Phoenix and Dr. Foreman in Cincinnati for our Q&A.
Well, hi, everybody. Hope you enjoyed the talk. We've got a couple of minutes to answer some questions. We got a couple in the chat box, so we can kind of start going through those. We'll start with a couple from Dr. Gupta, who asked two different questions. And Brian, I'll let you answer these because
Sure.
they're practice specific, I think. And so the first is, how do you deliver paralytic therapy, through intermittent boluses, becuronium or other meds? And then how do you adjust CPP, or some kind of general thoughts about how you adjust CPP?
Sure. So for us, the delivery of paralytic, we use becuronium quite a bit as part of one of our tier 1 therapies for intracranial pressure management, and we'll either do intermittent or continuous. It's patient specific, just in terms of how bad their ICPs rise with respect to stimulation. What about you guys?
It's usually cystatic curium is kind of what we tend to use for our paralytic, and then for our CPP goals, it depends on. I kind of agree. It kind of depends on whether you're focusing on ICP or you're focusing on the blood pressure parameters. We deal with traumatic brain injury largely, and so much of the initial focus in the first day or two are on adequate resuscitation and optimization of cardiac output and that kind of stuff. Really is more than anything else. So we tend to use kind of low dose pressors and that sort of stuff, unless the ICP is really out of control.
Okay. And then the question also about how we adjust CPP. I think we alluded to it a little bit in the presentation that, for us, it's, I think we stand, I think we start with our guidelines, and, our guidelines are CPP over 40 for children, but, we try to go age specific. It varies from the infant with an abusive head trauma to the 19-year-old who presents after a motor vehicle accident. We'll have different goals ranging from 40 to 60, depending on age. And then, I think, if we do make an adjustment based on our parameters, it like we kind of talked about, it's often based on some sort of provocative maneuver of assessing autoregulation to know, where is best for that specific patient. Sometimes, it's using, sometimes it could be using your Lycox, your NIRS, or your EEG, just to get a better sense of where things are. What about you guys?
Yeah, I was actually had answered the adjusting CPP question before the last time, so that tends to be what we end up focusing on. It's sort of based on response, I think, too. So if you're starting a pressor or levofed or something like that, and you're pushing your arterial blood pressure up and the ICP is going up, that's helpful. That kind of provocative test can be really, really helpful to help settle, okay, well, maybe this person needs lower CPP rather than higher CPP, or vice versa. One of the questions that came up from Professor Bleck is, could either of you speculate on the multimodal signatures of sustained depolarization? And that is a good and fraught question for a couple of reasons. So, sustained depolarization in this case could mean either a prolonged, spreading depolarization or cortical spreading depolarization that indicates tissue that is highly, highly vulnerable to cell death, or sustained depolarization, meaning if the tissue is depolarized and injured the cell death pathways. And in terms of multimodal response to spreading depolarizations in and of themselves, which typically are intermittent, there's some reasonable evidence that suggests that they create metabolic crisis, so changes in the lactate to pyruvate ratio, increases in glutamate, and potentially even glycerol, decreases in brain glucose. And interestingly, it can cause changes in the cerebral blood flow that can vary depending on the state of autoregulation. So when you have this massive wave of depolarization, the blood flow typically should increase to match the metabolic demands of that tissue. But in the setting of dysfunctional autoregulation, as we see after traumatic brain injury, for instance, you might get a paradoxical decrease in blood flow, brain tissue oxygen, and potentially an increase in intracranial pressure and even brain temperature. So they've got these vast effects, kind of depending on how large the areas involved, where the probes are, and that kind of thing, at least in the intracranial monitoring. When it comes to sustained depolarization, where tissue is depolarized and it's not coming back, that's a little bit different. And there's been some nice work out of the Penn group describing, for instance, the multimodality correlates of brain death that I think are kind of interesting. But since a lot of what we focus on is tissue, ideally that's salvageable. It's I'm usually looking for those signatures that some events, such as a spreading depolarization or cluster of depolarizing events, and kind of trying to look at what that's creating in terms of secondary brain injury.
Yeah, for us, I mean, we're still trying to figure out in our peds world how to find. I know you've done a lot of work with others on the adult side with COSVID and sort of looking for cortical spreading depolarizations. We do intracortical EEG in our population. We're still trying to figure out the right electrodes and right situation to know we're recording it well. So hopefully we'll see more in children in the future.
We've got one other question, and I think we've got a few minutes left. If other questions want to pop up, that's fine. But this question is: if you were to ask your nurses to provide one or two annotations that you do not currently have, that could help you interpret physiology in your reports, like changes nicely your EEG, what might those be? In other words, what are the least burdensome annotations that would provide the maximum value? What do you think?
I mean, the biggest thing is to know when they're stimulating the patient, when they're giving, when it's like when they're providing bed turns, just any sort of suctioning, that sort of thing. Because I think the biggest thing that everybody asks in the morning is, why did the ICP go up? And I mean, for a lot of our children who are doing okay and don't have malignant cerebral edema occurring overnight, I mean, those ICPs go up for stimulatory reasons. So if nurses are able to annotate for when they provide something that stimulates the patient, I think that could solve a whole lot of, like, why did the ICP go up overnight? In addition to that, I think it's for me, I'd also love if we could, if the annotation of hyperosmolar therapy, because we give it for bolus hyperosmolar therapy, that is, given it, really want to know if it was efficacious or not, and then helping you guide what you do next.
Yeah, we end up getting fairly good annotations for some of that stuff, and I find the behavioral things to be really helpful. I completely agree, because they, you see just massive physiologic changes, for instance, at bath time, which is like just deadly. But we'd never know what the heck it is unless you had someone saying, "Oh, we're moving and we're turning," whatever. Behaviorally is huge. For me, the one thing that I'm missing that I would really like is, and this would only be least burdensome from an informatics standpoint if you could connect the two systems, but basically sedation doses that are ongoing during the record, because we do see these periods of time where things just change. The ICP is suddenly higher, the blood pressure is higher, the heart rate's higher, and I don't know whether the sedation's been paused, when it's turned back on, whether that state that I'm seeing is an aroused state or actually a sedated state. And the importance there is, do you wean sedation or not? I mean, if it looks like this person really likes not being sedated, that's huge. But in many cases, obviously, we think they like to be sedated, but that's not always the case, because it drives blood pressure down and can induce states that actually look kind of harmful or not as nice as we would like for them to look. So, and what I mean by states are periods of time where you've just got physiology that's acting in a certain way, where your blood pressure is high, your heart rate's high, and your ICP is high. And if that's happening because that person's awake versus something else is going on, it's really, really useful to know. So yeah, having just medication in the background where you can kind of see where things stop or where things go up, what the dose is that someone's getting would be huge, I think. Another management question that came up was, what's the experience with the range of hyperosmolar therapies, which I think in many cases is kind of just related to what's available. So, for instance, we tend to use 23.4% sodium chloride where I'm at, but in the setting of shortage, which oddly enough we have had, we've relegated ourselves to 14.6%. And often, frankly, just use boluses of 2 or 3%, just because it's there in bags and easy to give. So, as long as it's hyperosmotic, it's okay with me. Brian, what do you guys do?
Yeah, we primarily do 3% hypertonic, saline or mannitol. I think we did, and in terms of my experience, we actually published this sort of exploratory study, looking actually earlier this year, just looking at, which patients responded and didn't respond to either mannitol or 3% hypertonic saline who had evidence of intracranial pressure. Our sort of retrospective exploratory analysis, we saw some evidence that certain model-based indices of intact cerebral autoregulation seemed to, before the therapy was given, seemed to correspond with the reduction, and that's something we're trying to study a little bit more. And we didn't really see serum sodium levels so much being as predictive of a marker, although, I think, but I think our experience has been mostly with 3%, and I'm excited sort of look at, what with multimodal monitoring, can we look for signs or or certain signatures before that tell us that a certain treatment might be efficacious or not, to sort of give us that precision medicine approach.
All right, we've got time for one more, and it looks like we've got one more in the box, which is I've read a couple of papers indicating edema is tightly associated with cortical spreading depolarization. Is that your experience? And that's a really, really interesting question, because there have been a couple of studies, one it's sort of biomechanical modeling of the occurrence of seizures or spreading depolarizations, and includes edema as a key factor. And another kind of recent paper, for instance, suggesting the nature of cerebral edema is related to CSF inflow, something that interestingly has some potential relations with what's seen in, for instance, electron microscopy of tissue that's undergone spreading depolarization. Things like dendritic beating and reductions in the extracellular space. So a lot of overlap between the two pathologies. What's not always clear is sort of the chicken or the egg, to me, clinically anyway. And of course, edema is fairly common, but depends on how you measure it too. But what I mean by that is that we often will have a traumatic brain injury patient with a CT that may look swollen, or at least seems like maybe there's some edema. But we use thermal diffusivity measures of blood flow invasively, and those generate a K constant, a brain water constant, and oftentimes those start as normal, even though we have a pretty high proportion that do develop edema. And in kind of the experience I've had, and the folks who've had edema kind of locally, so that brain water constant is elevated, for instance, our incidence of depolarizations in that area hasn't necessarily been as high as I would have expected it to be. So I don't know, the story's still out a little bit. There's definitely a bivariate relationship there, but what the nature of that is and its clinical correlation or relevance is a little hard to say. I haven't seen anything specifically, though. That's been a slam dunk, to use a basketball reference. I had to add something basketball related. Anyway, Brian, any thoughts on your end, Brian?
Yeah, no, I think we just don't. Yeah, for us, it seems to make sense, but yeah, we haven't been able to really tell where our cortical spreading depolarizations are quite yet. So hopefully, in the PEDS world, we'll understand that better in the future.
All right. Well, everybody, do you want to, Andrew, take us home?
Yeah, thank you guys both for doing what I think was a really great webinar. Congrats to you, Brian, on your publication. I think it's really quite something, and will help a lot. And then thank you guys for hopping on live for this Q&A. Thanks everybody for joining as well. I think we can probably call that a wrap. And oh, by the way, this will, of course, be released as a recording both on YouTube and our website sometime in the next week or so. And anyone who registered will get that in their inbox. So feel free to look out for that and share it around. So until next time, we bid you all a fond farewell.
Thank you all.
Thanks, everybody.